Thank you so much. Again, the reason why we're here is really to hear the patient's voice. It's behind everything we do. So I want to thank Mary for her comments. I think it's important to note that everything you said that built upon the morning session and some of the things we're going to be hearing this afternoon about goals of care conversations and what's truly important to a patient, and having a patient at the table at the very beginning. To go on a phrase somebody mentioned this morning, it's similar to the one I know: if you're not at the table, you're on the menu. And I think that was an Alice in Wonderland quote, but holds true, that you really do need to be part of that decision making and be there from the very beginning based on your values and what else is going on. As people make it to the microphone, I just wanted to go back to some of the things the planning committee wanted to make sure that we had actionable items that were takeaways that could either be implemented now. And looking back from the last session a decade ago, we want to make more progress than what was made the last time. So you've heard very innovative things like following the business model to help a patient when the healthcare system isn't working. And I think this afternoon we'll hear more of that. So we do have some questions, but I'd like to turn it over to the floor and make sure we honor your time and questions you have for the panel.
That was a great set of presentations. This is Evan Rosenthal, Medical Director at the Stanford Cancer Center. With respect to navigation, one of the things that we saw was that when we implemented a lay navigator program, was we saw that the separation of the navigator from the clinical care team was less effective and competed a little bit with social work. And so until we integrated the navigator directly into our disease group, that is, if they functioned outside of the care group and helped with things like parking and validation of the ticket and financial services, directions, things like that, it was less effective than if we put them in the care team and the patient saw that navigator not just as somebody from the hospital, but as like part of their care team was really important. And that took us about a year of figuring that out. And not only that, the care team themselves were suspicious of the navigator when it was outside the care team. They didn't know. So that's one question, I think. And then the other question I had was related to survivorship and the struggle that we have of implementing a survivorship program embedded in the care team is probably the best. But at the same time, it brings people to your tertiary quaternary medical center. It fills up the parking lots. It continues to drive a lot of busyness within the clinic where we're trying to think of having those off-site. So those are two kind of separate questions. One for Linda and one for Cynthia, I think. I don't know how you guys want to address that, but two separate questions.
Thank you. This whole word of lay navigation is something that's troubling to me a bit, in the sense that navigation, when we looked at our system, there were reported navigators that we probably had 30 different titles, seriously, in the same system: care coordinator, navigator, patient educator, clinical coordinator, et cetera. So what we did is we set up something called a peer volunteer program. And they are embedded in our system. So in other words, when I know that I'm going to be talking to a 35-year-old triple negative patient with 2 young children, if it's okay with her, I have her. All of our peer volunteers are onboarded as they are employed, so to speak, non-paid though. So they have background checks, they have their name tag, they have mumps, they have PPD. They can go and sit with somebody in an infusion. When Dr. Schulman asked me about how you leverage, I look at our volunteers as being extenders of the navigator, so they work side by side. It's a telephone-based program. The program's called WINGS, Women Inspiring, Nurturing, Giving, and Supporting One Another, and the men decided they wanted to be volunteers. So I said, okay, what are you going to call yourselves? We're going to be your wingmen, Cindy. We're going to be your wingmen. So I can pair up a newly diagnosed patient with a volunteer. I think we have to look at effective use of our resources And in this case, adding on more bodies, which I'm not always an advocate of, but is clearly something that's added value for the patient income, if you will. Does that answer your question? I also think that I'm not lucky enough to have a social worker where in our particular area north of San Francisco. So I've had to be a little bit creative in terms of how we look at how we leverage those volunteers in the various centers. Does that answer your question? Yeah. Okay.
So we struggled with the same thing in terms of space and how to really, because everyone's a little bit short on space. A few things happened. First of all, we build a new building, so we have more space. That's not necessarily the solution for most people. What we did was look at, if you really, in terms of practice reorganization, which is what I was focusing on, if you really look at the schedule and look at the templates, we had the APPs basically fill in the times when no one else really wanted to be in clinic, like Friday afternoons and late in the day. And so it's really a matter of being creative and recognizing that you have to work with what you have. The other part of it is we really couldn't move things away from the main center because these are really follow-up visits. These are patients who come in for scans, labs. There are set things in the pathway that they're, of course, not necessarily the longer term patients, but many of the patients are getting when they come in, and for a matter of convenience and billing purposes, they have everything done that same day. So it's really a matter of looking at the template and looking at what's available and seeing how you can do it. We also have other sites in our suburban areas that are opening up, and that we're considering putting follow-up clinics in those sites, like having one follow-up clinic, one session a week or a month, whatever the need turned out to be, and having all patients come to that, not disease specific, and having a provider who's comfortable and confident seeing different diseases, see the patient in that place. And that would also lighten up the schedule and the crowdedness at our downtown hospital, because there are many patients who live in the suburban areas in South Jersey, out in Radnor. If you don't know the area, you wouldn't get it, but it's further away from the hospital, who don't want to come into the city and pay for parking. And we're looking to establish programs and clinics there. Yes?
Would that be a primary care trained internship or a medical oncology APP?
It would be an oncology APP who is experienced enough and has seen enough patients in different diseases to feel comfortable following. And keeping in mind that follow-up care in oncology, especially long-term patients, is really exposure-driven. It's not necessarily the disease, it's how they were treated, what drugs they got, what radiation and where, what part of their body. It's not just the disease itself. So it would be an oncology APP.
In terms of the follow-up care, or whatever you call it, that's right after you finish your active care, I think it makes sense initially not to make too many changes. That's a scary, scary period for most cancer survivors, because patients, because in fact, now nothing's happening. You don't have that drug that's helping you. You're not being irradiated or anything. So it's a very scary period. So too much change, I think, would add to the anxiety and to the stress.
There's no change in the beginning. The patients who are completing treatment within the first few years, they stay in the practices that they're being treated by, and the APP in that practice provides the follow-up care. So it's someone who treated them is also doing the follow-up care.
And I just wanted to point out an important publication by the Oncology Nursing Society and the Oncology Social Workers, a position statement on navigation, because they are critical. You don't always have a dedicated oncology social worker. Those that do are tremendous assets to help with financial toxicity, so many things that can help shepherd that patient through the system, working as a team. But I think that that's a great resource for people to go back and reflect on based on what resources you have in your area. Yes.
One of the other things I think we need to look at again on leveraging is that we ended up doing what we call survivorship speaker series. So I realize when I'm doing a one-on-one survivorship care plan, that's one-on-one. But what I realized is nutritional support, cognitive changes, advanced care planning, all those kinds of things can be in a group setting. So most of my programs are philanthropically supported. So when I work for the community, so whether patients are a part of whatever healthcare system they are, we usually have seriously 40 people every other month coming. Sexuality, we're doing one this week on advanced care planning. So if you think about but a ripple effect of having 30 to 40 people hearing about how do I take care of myself? What is the benefit of exercise post-treatment? So they're not so frightened. They're not like thrown out after treatment.
So I also wanted to just talk about the role of supportive/palliative care in this, because many of our patients go on treatment hiatuses or in apparent remission for a bit, but they're very high risk of recurrence. And so we become that extra pair of eyes and ears as well, together with all the rest of the oncology care team, to use symptom alerts for risk of recurrence, and then also to keep the comfort going.
Thank you for pointing that out. I think that goes to Mary's point that when treatment ends, it feels like that security blanket. You're used to showing up, doing something, and then not doing something. You are worried about that. So making sure people are aware of symptoms and making sure they have a team to fall on is very important. To this side of the room, Dr. Nguyen.
Sure. Thank you. Again, this has been a fantastic day. I have two quick questions. The first one concerns, we all come from high-functioning institutions. And traditionally, most of our patients are particularly high-functioning with resources. As we think about navigation, though, in those areas, for me, Southern Illinois, South side of Chicago, that are limited resources with particular challenges, are the uniqueness to your programs of how you reach and how you have impact and how you follow up and impact in those communities? That's the first part of the question.
Believe it or not, when I was in Montana, and there were only 7 areas, it's the 4th largest state, obviously, and just reached 1 million people. I did all of what I do now out of a mobile home. I remember when I was invited to speak to some huge centers wanting to do survivorship programs, and I talked about an organic garden and a young adult hope, young adult help, and all the things I was doing. And I remember this person who will remain unnamed that bought a huge complex. He said, well, what is your cost per month? And I said, $400. He said, $400,000? I said, no, $400. I said, you know your nonprofit's in trouble and it's got more wheels than your car. But you can do innovative, novel things in low resource areas if you still have the same principles of service in place. It doesn't have to be, I learned that, it doesn't have to be a big fancy building. It has to be navigation without walls.
And Dr. Nguyen, as you know, the National Cancer Policy Forum has often invited speakers, international speakers, and I know we have some folks with experience in third world countries where they've actually found something that's done better there that they've come and shared here. It's not that just because we have all these resources and we spend so much of our gross national product on healthcare that it's always done the best way. So people with very limited resources get very creative and they end up finding new ways to do business, so to speak.
And I think the part B of my question is, how do you see navigation as stimulating the economy within some of those neighborhoods? In the context of developing workforces within those same neighborhoods?
In order for the economy to be stimulated in some way, we have to treat navigators as the professionals that they are, which means they're paid. And that's not the case in many settings. I don't know what happens in your settings, but in a number of settings, that's not the case. In some places, they must be certified and they are paid. They probably are not going to go out and buy, a chateau anywhere, but they earn a living and they add to the economy in the area. Unfortunately, many programs are really on a shoestring. They're really on a shoestring. Most people value the programs and they say they do, and they do good work, and I've heard very few people say that that's not the case. But I also have heard very little enthusiasm for paying them.
Thank you. Dr. Schulman?
So my thoughts are a little bit along the lines of some of the things that have just been mentioned, and also responding to some tweets that we've been getting. I don't know how to tweet, but somebody else is answering the tweets that have to do with, well, this is fine. You can do all this stuff in high resource settings, but, it's not a realistic thing. And aside from the tweet, what the comment I was going to make is that I think that there is a business model for this. And Cindy and myself and a number of others are writing a paper, a little bit of a derivative out of one of our workshops a year or so ago on navigation, about the business case for patient navigation. And it's actually pretty clear that healthcare organizations financially profit from navigation services, even if you can't bill for those navigation services. And that's a whole separate issue. I agree completely with you that it should be a billable service. And Linda talked about some metrics for survivorship in the follow-up clinics that would allow an increase in new patients, who are the ones really, frankly, who generate a lot of the revenue and margin for our cancer programs. I think it may be a little bit harder to sell for palliative care because the metrics are a little different, but they're probably there as well. And if I had a magic wand and I could make this happen the way I think it should happen, not only would I have these services, but I'd actually have a lot more people providing the care in each of these services. And Linda's done this sort of without really increasing the number of APPs, but I think we need a bunch more APPs doing it. I think we need more navigators than almost any of us, any of us have. And there is a constriction in the palliative care workforce. We don't have enough palliative care providers to go around in the country, nearly enough. And so they need to be used as wisely as possible, because that pipeline is a slow pipeline still. But I would envision, if we were to do what I think we really should do, there'd be a lot more of all three of these categories of people in our practices that would allow us both to provide better care for the patients and more efficient care for the team. Goes back to what was said earlier this morning about team care. And I think we could prove would be financially the right thing to do. Without that piece, in the current healthcare environment, it's going to be very hard to get administrators to start to hire these people. So I think coming out of this workshop, that has to be one of our challenges, is how do we make the case to do this? It's fine to say that it provides better care, but unless we can make a business case for it, I think it's going to be very, very hard to actually make it happen in any significant way and broadly.
Because even those in low resource areas, even the highly resourced academic centers may not all, from my knowledge of those that have implemented it, they didn't have a budget to hire a bunch of navigators. They survived off of research grants to try to prove the case and move that along. So going to Cindy's comment about navigation without walls and involving that outer rim of the community, I've seen in low resource areas where the community is what's taking care of those patients when those resources aren't available or they don't have access to a healthcare institution. So we could learn from the low resource areas of what's working well and apply it even into the high resource areas where patients might be getting a lot of care. They just may not be getting with the care they need and that they desire. So I think that that's an important point to share for the folks that are also tweeting in. But I definitely hear your point about what needs to come out of the proceedings of this workshop, not only identifying the innovative models that have been shared in this session, but also any gaps that we've identified.
So
and I think
I could imagine a white paper coming out of this that doesn't focus on each of the individual groups, but focuses
the themes
on how to put these three groups of providers together to support a better care model.
Right, and Dr. Portman had a comment.
Yeah, I think the really fantastic news in palliative care is there's actually a very well developed and vetted business case that's been made that it spares acute healthcare utilization quite well, and that once admitted patients who are admitted who get palliative care consultation have shorter lengths of stay and more seamless discharges. So I think it's a real model how that business case has been built to use for other endeavors in oncologic
And
care.
they survive longer.
Some do, yeah. So I'd love to see some of those business case models actually be employed to support the other disciplines here.
I just wanted to comment that APPs in our institution do bill, and despite the fact that they can bill, it's been a very difficult sell for the institution to agree, and that's to support the program at all. And that the only way it could move forward was by saying it would not cost any money, any additional money, and utilizing the APPs that we had and reorganizing our approach to managing follow-up care, when in fact, follow-up care is really helping all the practices by pulling the follow-up patients out. It seems like it makes no sense not to do it, but it didn't really matter. Even though I had one of our finance people put together the numbers and show how much money could be brought into the health system if they were to put the money up front. No one was willing to put the money up front. They said, prove it to us, and then we'll support it. Well, that's sort of impossible.
Hi, Ruth Niemeyer from the American Association of Colleges of Pharmacy. And so to ensure that education gets to be a part of this forum, I've said education, but I wanted to sort of respond to both the palliative care and the Navigator. When I was a dean at the pharmacy school in Harlem, all of our students were trained at Mount Sinai, and this was 10 years ago, in their Navigator program. And, I often think that we educate the empathy out of our students, and somewhat indicated that this morning. And that if we have 142 schools of pharmacy, 142 schools of allopathic medicine, about 20 schools of osteopathic medicine, and lots of nursing schools and social work schools, all of those students need to be involved with patients, especially if we have any hope for changing our healthcare system. We need to start it at that model, and that early on gets them involved. There was all kinds of great comments from our students about being involved early with those Navigator programs, and from the patients and from the healthcare system. And so in that model, it worked very well. So I don't know if you want to speak to any of you who have probably incorporated medical students, pharmacy students, nursing students into your programs. And the other thing is prevention. And the Mount Sinai had a prevention program because in the area we were, people weren't getting colonoscopies. And we increased those colonoscopies and vaccine rates for flu by like 1,000%. So let's get our students involved.
Thank you so much, not only for getting students involved, but also for the pharmacy perspective. Because I can speak to how valuable not only pharmacy students rotating through, but the PharmDs that are educating them and actually running independent oral chemotherapy agent clinics that then help decompress an infusion suite or the navigation team. So thank you so much for the pharmacy perspective.
So as I was racing through my last slide, you may have noticed that I mentioned pharmacists. And for us, clinical pharmacy has been absolutely indispensable sort of team-based intervention. And we find that the study that was just done that showed the amazing return on investment of any one pharmacist on a palliative care team or oncologic team has been well proven in our system. So we do have pharmacy students that rotate with us. We so respect and embrace our clinical pharmacists as core members of our team. And thank you for bringing that forward.
Brenda?
Brenda Nevijan, ONS. So at the State of the Union in 2016, President Obama launched the Moonshot Initiative, put Joe Biden in charge of it. And what framed that was trying to shorten the 17 years of research into practice. Now, some of you have had long lead time getting your practice changes in place in your organization. So what I would ask is, with that retrospective view, what would be things that people today could do to not have it take 10 years or 8 years or whatever to implement these kind of practices? I feel that sometimes the chicken and the egg, Linda, that you said, we need the support, well, prove it, then we'll give you the support. I mean, that's crazy making. But as you think, what are some of the things that are available today to shorten this window to convince organizations that there are things they could be doing that will improve, whether it's access into an organization, journey through the organization, the humanity that we're talking about, those kind of things? Anybody? It's
Well, I just wanted to comment briefly that I think we're in a very different place now than we were 17 years ago, in that we have data. We do have data that demonstrates improved patient care, satisfaction, in terms of access. We do have it. And there's been a lot of studies looking at this, which there weren't 17 years ago. So I think, like I said, I think we've gained a lot of momentum in the last 3 years for a lot of reasons, including the fact that there are more centers around the country doing this, as well as organizations, as much as we may complain about things like requirements from the NAPBC and the COC, that's heightened everyone's awareness that we must be doing certain things for our cancer patients along the entire continuum of their care. So I think that people could jump in right now and put some very effective programs into place utilizing the experiences other people have had.
Thank you, Brenda, for mentioning the Biden initiative and the Moonshot Award. What was so intriguing to me was at the summit, the innovation with respect to, now I really do call Lyft. Now they do give so many free rides. Now I utilize Airbnb. Now I'm able to use some of those innovations. I think it goes back to beyond thinking about what we do in our cancer centers, but how do we broaden that community interface and bring it back so that it's really a dynamic process of our community caring for our community. You know, cancer centers used to be a part of the community. And somehow we kind of got, at least maybe because I'm from rural areas predominantly, but I understand that we need to think more innovatively. So,
Deb Mayer, National Cancer Institute and University of North Carolina. I appreciate all the speakers' comments about this, but in many ways, it still feels like we're nibbling around the edges when you think about the sheer volume of what's here and coming down the road. And much of what we talk about is, although we've talked a little bit about doing assessments up front, is throwing everything at everybody and not really talking very detailed about how do we triage in a way that we can deliver to high-risk patients and help self-manage the lower-risk patients and what have you. And I think that every one of these topics should be putting that filter on things, because we can't do this for all people. All people don't need these kind of resources. And how do we sort of deliver right-sized care as we go along, and how long it's going to turn to sort of shift the tanker. I mean, what they say that to turn the Titanic around, to turn, you know, on a dime would take, 6 miles to make something like that turn around. And we know how slow things are going, and it gets me very frustrated to think about how resistant we are to changing models. And what we're talking about here isn't really big changes that we're talking about. And I think we're going to have big changes to make some of the care delivery we need to be giving available to people.
To your point, I think some of our speakers on the slides, it was nice to see exactly what you said. They called Stratify it. You called it triage, because not all patients need everything. It might go to a survivor plan and move on. Others who are high risk, where there could be a second primary or recurrence, that team is going to focus their efforts on that population. And then it was also brought up the importance of training other folks outside of oncology and radiation oncology and palliative care to take care of these patients, because one size isn't going to fit all. It's not going to fit geographically based on resources. So you raise a critical point. I'm really worried that we're not going to be able to write it in time for when we have a decreased workforce, people not specializing in oncology, and I think it will fall to many other caregivers, including the patients. So one of the things that the planning committee thought about, and our presenters, was also what strategies could be implemented to more effectively engage and support family caregivers, because I think that's going to be one of the solutions that is going to come into play with this. So I would ask our panel what other strategies they think can be implemented for that.
I think that the first is the recognition of the critical role that they play, and that was spoken about this morning in the presentation. I think that some of the digital solutions that I talked about are directly applicable to the home environment to help the caregivers be empowered with strategies for illness management through apps and such to be very actively involved. And then training programs within centers or community practices that officially train caregivers to do care. So I know, for example, in our center, there's a very well-established and developed training program for caregivers of those who've had bone marrow transplant. I think that exists in many centers. Those types of models that involve APPs or nurses to do the training that equips these caregivers to move forward and feel empowered and know who to call if there's any issues are so important.
And thanks, because my follow-up was going to be, and what would they best be able to handle? And it sounds like items that you may think they may not be able to, they can, based on even the supplemental training programs.
Hildy Dillon, Cancer Support Community. So I think it was Cynthia that said to reach out to the community. So I think that you have to, I mean, people are saying here that struggling with the return on investment and having a good, solid business plan to make these changes happen. And the reality is that they won't happen fast enough across the spectrum of every place that's delivering oncology care. So I would say that one of the recommendations should be to proactively partner with community organizations that are providing services for patients and caregivers that the oncology care services, that the clinical services are not able to provide. Where COC requires distress screening, and so almost every center is doing distress screening, but they may not have the staff to help people through their distress. So organizations like ours, we have mental health professionals that are providing emotional support counseling for patients and for caregivers. So I think that there has to be short-term and long-term, and part of the short-term is partnering with the community organizations that are professionally also servicing this community.
Thank you. And I think that's very important. And I would also take it a step further. As a former cancer program director, we actually not only engaged the community, we had members of those organizations on our cancer committee. So they were part of the development of the goals of the committee for the year, having patients' voices of what the patient's needs were, whether it was distress, whether it was transportation, financial toxicity, what have you. So thank you. I think that's a real valid point that needs to be captured as part of the proceedings from this workshop.
Can I just say something about the community at work and what you can get, how the community supports things that are important to them? We had a small organization in Washington called Neighborhood Health Champions. We had a very, very small grant. I think we got $10,000 or something to fund it. We trained 20 community health workers, and 2 years running we had a health fair, a health day. We didn't want to call it a fair. We wanted it to be more than that. And we had more than 40 organizations in Ward 7 in Washington, D.C. If anybody knows what Ward 7 is, it is one of the least well-served wards in the city. We had more than 20 small businesses donate food. They donated money. They donated goods. They came in and did some of the construction for us because they knew it was about health. They knew it was about their health. We also included all kinds of other services there. We had someone there who was talking to people about their credit reports and all of those kinds of things. So the community steps up if you let them know what it's for and they see that you're providing a service. We didn't have money to pay the community health workers, but we gave them, and they didn't know this when they applied applied and when they were accepted. But we gave them a small, one of the gift cards. I think once a month we gave them a $25 gift card or something. My mother supplied food for us to eat when we had our things. So, she did. She's a wonderful cook. She made chocolate cakes and banana puddings, and people started wanting to come to my house and eat. I told them I didn't cook it. But seriously, the community came together and did that. And I want to say one other thing that I want to make sure people understand about Navigators. Navigators are not, the process isn't driven by zip code. It's not about poverty. Everybody deserves a Navigator.
Thank you. Well said. And I think we have 2 minutes. Time for one more question.
Good afternoon. Ann Ireland on the ONS Board of Directors. Thank you so much for your wonderful presentations this afternoon. I'm going to jump off of a comment that Brenda made this morning that I think none of us picked up on, and I'm sitting in my chair going, this is crazy making, because many of us are doing survivorship care plans because we've been told to. None of us are willing to send our patients back to their primary care providers because we love them too much and we want to keep them to ourselves. So the crazy question is, why are we still doing survivorship care plans?
Okay. I'll let Larry answer this for the specifics, but I just want to comment that I think people are too hung up on the idea, and because we've had to be, the idea that it's a separate document, a care plan, a thing we're creating. And you're right, it takes a lot of time and energy, but every patient should know what their treatment was. Everyone should have a treatment summary, regardless. So that should be carried over. And every patient should know what they need to do for the next year at least. Do I need a mammogram, a colonoscopy, et cetera? That's why we've started using the patient's note at the visit that they're coming in for, their routine follow-up visit with surveillance, et cetera, as their care plan. This is what you need to do the next year.
And that's important because it's just like performance measures. If you give good care, the performance measures will take care of themselves. So this is a model and an idea that they've done it to make sure that they're meeting the need, but not reinventing the wheel or having more time consumed with developing a plan. And I'll let the last word be Larry's, the last 30 seconds.
So I don't know if you know, but I'm the chair of the Commission on Cancer, and this is all my fault. Yeah. So I wrote the standard in 2012 and modified it afterwards, and I will say that it is under discussion, as are all the COC standards at the moment. And we've gone through a very extensive process about whether providing a survivorship care plan and treatment summary is a good thing or not. And we don't have time to go over this. Actually, the forum ran a workshop on survivorship maybe in July of 17. I can't remember. And we addressed it then, and we've addressed it at several other forums. It's clearly not what makes survivorship care or follow-up care good or not. The one thing I will say is that by making this a standard for COC, it got it on the agendas of 1,500 hospitals, most of whom had no plans for survivorship care at all prior to that. And to some extent, I feel like we've accomplished what we wanted to by doing that. The programs are now paying attention to survivorship where many of them didn't before. I can't tell you whether we will continue to require the administration of survivorship care plans, but I would say that I think Linda's points are key, which is that, frankly, every time a patient comes in, they ought to know what they need to do over the next period of time, what services they need. They should be arranged for them. That's just good care. And the main trouble I have with survivorship care plans is the COC and the rest of us view it as a single episode, whereas survivorship care is an ongoing event. So having said that and hedging a little bit, I can't tell you where the COC will end up, but we should know in a few months.
And we'll end it there. Thank you, Larry, and thank you to the panel. It's now time for a break, and please return at 3:15 for the next session. Thank you.